Okay, hi everyone. I'm sorry I was a few minutes late. We had a motivational speaker for the ultrasound department. So he came in and gave us a talk for 1 hour. His name is Juan Bryant. He was just phenomenal. I have really many things that one wants to say, one wants to, but are left unsaid, and really team building and what is expected of us, and just reminding us that I have introduced him to Elizabeth just now, and they've exchanged cards, and so they will set it up for the residents as well. What was very important, what I understood from him, is that the most important thing that I took back, that if within ultrasound we're the healthiest we have ever been, we've got the best techs, everybody's attitude is great, everybody's performance is great, but he said how we could go even better. So it was very helpful that we did this for our section, and we'll do it for radiology as a whole. All right, today I'll talk about the ultrasound evaluation of venous insufficiency. I've got some text slides, some image slides, and I've got 2 videos. So I'm hoping they will play and we'll go along with that. If there is a question, please ask me, and you can interrupt me at any time. All right, so when we talk about the venous insufficiency, we're really interested in this vein. I mean, we're really interested in the great saphenous vein. The lesser saphenous vein is also important, but ultimately it is the great saphenous vein which causes majority of the symptoms, because it's got the lengthiest of the course and it drains majority of the lower extremity. So the great saphenous vein is the major superficial vein of the medial leg and thigh. It is the longest vein in the human body, extending from the top of the foot to the upper thigh and groin. The great saphenous vein plays an important role in returning blood from the superficial tissues of the leg to the heart, and is also used in several medical procedures due to its size and superficial location. So can someone tell me what would be the potential ways great saphenous vein is used in the body, Bhavna? When would you harvest it? For dialysis, okay. Why else? For a cardiac bypass, good. Any vascular injury bypass, anything forever, the great saphenous vein can be used. The reason why it can be used is, number one, it has a very long length, and it has significant 4 centimeter, 5 centimeter length without any branches. So the surgeon doesn't have to go in and keep tying and ligating off the branches. So there will be a sufficient length which can be used as a whole, number one. And number two, whenever you use a vein in an arterial scenario, it has been proven in many mice models, etc., that endothelium starts to develop within that vein. So it is a very easy vein to arterialize. Does that make sense? All right, so this is what we spoke about. Let's take a look. So this is the dorsal venous arch of the foot. And then you have this very long vein that comes up along the medial calf, stays medial here in the popliteal fossa, and comes superiorly all the way up to the opening, the saphenous opening, where it drains into the common femoral vein, and this is all medially. So this is the longest vein of the human body, even though it seems like that there are many tributaries, but there are several lengths of the tributaries where they're very, very small and can easily be harvested. So this is another image telling us the same thing, that this is a great saphenous vein. So if you see from here to here, other than the small perforators, there's a rather long length that can be harvested with success. So I've done a lot of surface marking because it's easy for us to say where it is, but when the ultrasound technologists are actually going to scan every millimeter of this vein, it is a painstaking evaluation. So when we do the venous reflux study, and I will explain that, it takes about 45 minutes to 1 hour, 15 minutes to do it on a patient. It's not a quick in and out exam. Look, put the probe on, gallbladder calculus, yes or no, and move out. No, it's a very tedious exam. And it was very tedious for me to teach it to them, and very tedious for them to perform it initially, and now they're picking up some speed there. So we really need to know what is the anatomy of the saphenofemoral junction in order to know what we are looking for. So right at the saphenofemoral junction, I will show it by the diagram, you have the common femoral vein that divides into the profunda femoris and the superficial femoral vein, you all know that. And then you have the superficial veins, which is the great saphenous vein. I just want to let you know one thing about nomenclature before I go any further. So the great saphenous vein is also known as the long saphenous vein. But if you use this abbreviation, you will confuse this with the lesser saphenous vein. So in our hospital, in my department, we are not going to use long and short saphenous vein. It will be very confusing. We are going to be using great and less, greater saphenous vein and the lesser saphenous vein. Because if you use LSV, it could be long saphenous vein or lesser saphenous vein. That could be conflicting, could mean different items. So we're only going to use greater. and lesser saphenous vein. And then these are two major tributaries that come and feed into the lesser saphenous vein in the area of the saphenofemoral junction called the medial accessory saphenous vein and the lateral accessory saphenous vein. So let's look at this in detail and see what's going on. So this is your greater saphenous vein, as you can see. It has a large tributary called the lateral accessory saphenous vein and the medial accessory saphenous veins. Whenever the saphenous vein is harvested, it is usually not harvested close to the saphenofemoral junction because these are major tributaries which will need to be ligated. This is the common femoral vein that divides into the superficial femoral and the profunda femoris vein, and this is the saphenofemoral junction. In every patient that comes to the ultrasound department for even a DVT examination, the saphenofemoral junction needs to be identified. It needs to be identified whether or not at the saphenofemoral junction is the common femoral vein compressible. So you will see on the images, it will say CFV at SA, at the saphenous opening. And we need to identify if the thrombus at all traveled into this superficial venous system. Two things about the superficial venous system, that it is a very slow flow system. The velocities are not high, they're not the speed of light. It's an extremely slow flow system. So you have to keep augmenting this by doing distal compression, by trying to elevate the limb, so on and so forth. That is why it is a tedious examination, and your spectral tracings are very, very low velocity. We'll talk about the lesser saphenous vein now. From its origin, its course around the lateral aspect of the foot. So greater saphenous is medial, so lesser saphenous is lateral. This is the inferior and posterior to the lateral malleolus. It runs along the posterior aspect of the leg. Usually it drains into the popliteal vein at or above the level of the knee joint, and that is called the sapheno-popliteal junction. All right, so very easy. So this was the medial malleolus. This is the lateral malleolus. Coming from the lateral malleolus, running in the middle of the calf, this particular vein, which is the lesser saphenous vein, goes and drains into the popliteal vein at or immediately above the knee joint. Any questions regarding anatomy so far? Okay. All right, let's talk about the sapheno-popliteal junction. That in itself has some merit. To determine the competency and the relationship to the knee crease. So you have to do, in our institution, the vascular surgeons do not treat reflux that is isolated to the lesser saphenous vein. Does that make sense? If there's a patient that comes in has reflux in the great saphenous vein and the lesser saphenous vein, they will treat. If there is lesser saphenous vein incompetency alone, they do not treat. So it's departmental protocol, or they say they told me that the benefit is not that much if you just treat the lesser saphenous vein. So in institutions where they do and the patient does go in there, you have to take a surface marker like a Sharpie or a skin surface marker and mark, with an X or with a line where the lesser saphenous vein is entering the popliteal vein. The junction is commonly into the lateral aspect of the popliteal vein, and you obviously want to know there are variations, the muscular veins. If you do not identify the sapheno-popliteal junction, there is a Giacometti vein, which is a normal variant, and this vein will go straight up to the superficial femoral vein and drain there. So when it's a normal variant that the lesser saphenous vein does not drain into the popliteal vein, instead it continues up into the thigh and drains into the superficial femoral vein. Is that all right? Okay. All right, so this is again very simple, that this is here they're saying a short saphenous vein, because we are not going to be using that. We're going to call it lesser saphenous vein, drains here into the popliteal vein. At times, it may not drain here. It may continue up as this Giacometti vein, which will then drain anywhere into the superficial femoral vein. Does that make sense? Okay, great. So we've got this. So I've just got this image to show you where both the veins will be. Many times the techs will call you for troubleshooting. They'll say, we can't find the lesser saphenous vein. We can't find the greater saphenous vein. So unless you know the anatomy yourself, how are you going to help them, right? So you need to know, if you remember that the greater saphenous vein is medial, then automatically you will remember the lesser saphenous vein is posterior. So very easy. This is just showing us a course of the great saphenous vein, course of the lesser saphenous vein. All right. One more important thing. There are several arteries, deep arteries, for example, the superficial femoral artery. It gives many muscular branches that come anteriorly towards the probe. It gives several muscular branches that may be right here. Sometimes you may confuse them with that of a great saphenous vein. Always remember that the great saphenous vein travels in a sheath. So when you have difficulty in identifying where it is, look for these parallel white fibers. This is the sheath in which it travels all the way from the calf up to the groin, okay? So I tell the techs, if you can't find it, look for those parallel white lines, which is the sheath. And that is an easy ultrasound landmark where you can identify the great saphenous vein. So let's take a look. So this is, it's called the saphenous sheath. It travels within the saphenous sheath, and this is what the saphenous sheath looks like. It could be parallel lines, or it could look like this, like a biconvex area. So that is one easy way to identify where these veins are. So this is a video I want to show. Just bear with me, and I'm hoping it will pull up. I will copy and paste it somewhere. Okay, so it did pull up. Now, how do I show it here? It's pulled up here.
You just copy it and paste it in your browser.
Someone will have to come and help me. So it's working here, but it's not displaying here.
It's here?
Yeah, this is the one. Oh, okay, great. Thank you so much. Okay, thank you so much. This was an animation, and I wanted to show it to you. So, all right, Sylvia. Now, Sylvia and Laura will not sit together in the next this thing. When my son in second grade talks too much to the neighbor, then we have to change positions. So, Laura and Sylvia will not sit together. Okay, okay, Sylvia. In the really? Okay, no personal discussions. At work, no spouses, only colleagues. That's how me and Chaitanya are also, right? We're only colleagues. Okay, anyway, I'm just joking. Sylvia, when you look at an ultrasound, a DVT ultrasound, right? Normally when they do the ultrasound here, what color is the vein? Is it blue or is it red? It's blue. Why? Because the flow is from caudad to craniad, right? It's going from caudad to craniad. What should be the normal color in the great saphenous vein? In the normal great saphenous? Blue. Very good, because it's draining blood from the medial malleolus to the calf, to the thigh, and then draining it into the common femoral vein. So I want you to look at this. This is what is normal. The deep vein flows towards the heart. The superficial vein also flows towards the heart. That's number one observation. Number two observation is that from the superficial vein, blood is only allowed to flow to the deep vein. Going from the deep vein to the superficial vein is not allowed because there is a valve here. Okay, this valve precludes any flow from the deep venous system to the superficial venous system. So have we got this done? We've got that the flow direction should always be cephalad, number one, and it should always be superficial to deep. Any questions regarding this? Because if there are, then we cannot go on. Okay, great. So this is what's normal. Deep vein going towards the heart, superficial going towards the heart, superficial coming towards the deep vein. There's no question here. All right, let's go to what would be abnormal. Abnormal would be number one, if blood from the deep venous system is allowed to flow upward, right? Go towards the superficial venous system. That is a problem. Second problem would be if blood within the superficial venous system is allowed to flow back, right? If the flow is from the crania to caudad, that's wrong. If flow is from deep to superficial, that is wrong. So we've established what's normal, what's abnormal. Okay. Both conditions, if blood is flowing from the deep venous system to the superficial venous system, challenge the superficial venous system. The superficial venous system is a slow flow system. If you are going to load it up with more and more blood from the deep venous system, which is a high capacitance system, then you are going to cause focal dilatations in that thin channels. Obviously, you pump in 5 liters of blood in something that has 3, whatever, before it bursts, it actually will start dilating. And then these focal areas that are dilating will allow blood to swirl, just like a pseudoaneurysm. They will allow blood to swirl. So with distal augmentation, okay, second thing I want to tell you, sometimes venous reflux may not be identified at rest. Okay, if I have venous incompetence, maybe you can't identify it at rest unless you augment it with distal augmentation with Valsalva. What does Valsalva do? Laura, what does Valsalva do? Valsalva maneuver, yes. It increases okay, so what happens? Good. So when you do the Valsalva maneuver, what happens is you're compressing the IVC. Exactly. You're putting pressure on the IVC. When you're putting pressure on the IVC, you are taking the venous return from the limbs to be sluggish, right? There's a moment of stagnation, or there is a moment of sluggish flow. When you compress the IVC, blood flow from the lower extremities becomes slow. At that time, it challenges the superficial venous system, because if this valve is not working at that time, blood cannot go forward, it starts to go upward. So that is why Valsalva maneuver is required every time you interrogate a segment of the superficial venous system to produce the reflux, right? When you go to a surgeon and you say, I have a hernia, what does the surgeon say? Yeah, you have hernia? No, he says, do Valsalva, cough, do this, bear down, and things like that. He wants to produce the hernia, right? Likewise, we want to produce the reflux so we can document it on ultrasound. So number one, Valsalva maneuver. Distal augmentation. Who's next? Brad, who's trying not to make eye contact. Brad. Okay. Brad, what does distal augmentation do to the venous system? Where? Will increase? Yeah, venous return, right? So if you pinch a pipe, the flow increases, right? So if you pinch the calf, you augment at the calf, it increases the volume of blood. So when you increase the volume of blood flowing through here, again it challenges this valve. And it causes blood flow to go in the opposite direction. If this valve is we are trying to prove that this valve is incompetent under stress. Correct? That is our objective. We are trying to prove that the saphenofemoral junction is incompetent under stress. And we'll give you the stress. We'll give you Valsalva and we'll give you distal augmentation. That's what we are trying to do. So here it says, with distal augmentation, the flow initially goes cephalad. It then refluxes back down the leg through the malfunctioning valve. So we got that. Initially it goes upward, then it refluxes, and then it can flow in the opposite direction through the superficial venous system, right? So that is one thing. That's all. That was all regarding this particular. Now, how do I go back to my presentation? Only standing up. So examination of venous reflux, when in each of our ultrasound rooms, we have a little table or a little stool, and the patient stands on the stool and the technologist sits on a chair, and that's how we scan it. In India, we would make the patient stand on the table and try to scan. I don't know why we did that, but we didn't have stools. But yeah, but here we make the patient stand on the stool, and the tech sits on her chair and she scans. It's a very tedious exam trying to pick up reflux and to at the same time freeze that image. So give some consideration there. So has everybody understood what is abnormal? What is venous insufficiency? Venous insufficiency is flow in the great saphenous vein that may not be from toe to foot, and second, that yes, Dr. D. We use, for the venous insufficiency, we use Valsalva maneuver and distal augmentation. For the hernia exams, we use coughing also. Everybody clear so far? Okay, great. All right. So this was just those images. All right. So number one, patient must be scanned in upright position, and that limb should not be weight-bearing. So if you're examining the right lower extremity, have the patient access to the table where they can bear the weight on the left lower extremity. The right limb, the limb that is being examined, should be non-weight bearing. That's number one. Number two, what is our exam protocol? Please understand what is the exam protocol. Only then you will be able to help the technologist. The venous insufficiency ultrasound exam has three major components. Number one, patency. Hunter's turn to answer my question. He went away. Now it's mini Hunter. Okay. Since you have not had an ultrasound rotation, I will skip you. Now it's Ahmed. Ahmed, first thing is patency, a complete exam of the deep and superficial veins of the lower extremity for evidence of acute or chronic DVT. Why is deep venous thrombosis the first step in performing a venous insufficiency exam? Are you Ahmed? Not Ahmed. Ahmed, tell me. Why do we perform a DVT exam before we, as the first step of performing an insufficiency exam? If it's clotted, so? If it's clotted, what's going to happen? From the superficial vein, right? So he's right. If the common femoral vein is clotted, let's say the common femoral vein is clotted, where does the superficial vein drain into? It's got no way to drain into, right? Automatically it will start stagnating. Blood may start swelling. Is that correct? So you don't want to do a venous insufficiency exam, number one, in a patient who has DVT, because that might falsely give you reflux. Number two, you might augment that reflux and that clot all the way to the heart, right? You're doing calf compressions 25 times in that lower extremity with a DVT. Where do you think that deep clot is going to go? It's going to go all the way to the right atrium, right? So as soon as you identify a DVT, you say, we can't really do a venous insufficiency exam. You let them know, you call the doctor, that when there is complete resolution of the DVT, patient comes back for the insufficiency exam. Any questions? Okay, great. So first is there a DVT or no? No DVT, proceed with a venous insufficiency exam. In the venous insufficiency exam, now you're wanting to do reflux study, assessment of any retrograde flow in the deep and superficial veins of the lower extremity. So basically, you do distal augmentation so that you may have, and you want to produce, yes, was that a yawn or a stretching? It was a question.
So if they have an EEG in the deep or a superficial venous thrombus, that's the end of the exam?
That's the end of the exam. That's the end of the exam. There you said that this is not, they've got bigger problems to take care of right now, rather than, cosmetic varicose veins, right? And
I was going to say something, but if you have chronic venous insufficiency, you can have chronic DVT, and that causes valve insufficiency. So, in an acute setting, yes, but when you have reperfusion after chronic deep venous thrombosis, then you have secondary insufficiency, and sometimes that's the indication for you to do this test.
yeah, in patients with, he's right, in patients with chronic DVT, the recurrence of DVT itself can cause the valve to become incompetent, right? Because of scarring, that is why. That is the reason for that is scarring. The patient had a DVT resolved, had a DVT resolved. So there's multiple episodes of DVT, scar the valve, and then that valve just remains open. Okay? All right. This is the patency exam. Any questions? Louise, you have a question? The patency exam will consist of transverse compression exam of the lower extremity veins for DVT, the common femoral, superficial femoral, popliteal, posterior tibial, peroneal, and greater saphenous veins should be evaluated in this fashion. So you're just looking for DVT and superficial venous thrombosis in the first step. The vein will be compressed sequentially every 1 to 2 centimeters with moderate probe pressure. Then vein should be observed to completely coapt and then reopen as pressure is relieved. So when we do a DVT study, bless you, when we do a DVT study, it's not just the vein is compressing. That's the active phase, that the vein compresses when you apply probe compression. Then there's a relaxation phase. The vein opens up when you release the pressure. So both parts should be observed by the technologist. This is again how to go on. Place the transducer on the mid-superficial. I will show you a video so you don't think this is the only thing. But place the transducer on the mid-superficial femoral vein and have the patient do Valsalva while recording the spectral Doppler tracing. If the Valsalva maneuver does not cause retrograde flow, then squeeze the thigh distal to the transducer to cause augmentation while recording it. So basically exactly what I told you. So the great saphenous vein, let's come right here. The transducer is then placed on the great saphenous vein near the origin, that is at the saphenofemoral junction, and a spectral Doppler tracing is taken with Valsalva. So you identify the saphenofemoral junction, you put your transducer there and have the patient do Valsalva and record the tracing. Distal augmentation is also performed if Valsalva maneuver does not cause retrograde flow. So if the patient has done Valsalva maneuver, you have stopped the amount of blood going into the IVC, automatically that incompetent valve will kick in and blood will start going to the superficial femoral vein and in the opposite direction. At that time, if you have documented, you are done. You are done. But if you cannot document with Valsalva, you have to go do distal augmentation. Correct? If coughing is producing the hernia, that's good, right? But you don't do coughing, now this thing, now do that. No, you have produced the reflux, you've got your answer. One important variant that we need to take care of, so now you have to do the great saphenous vein evaluation in the junction, proximal, mid and distal thigh. So all the way down. Then you do the evaluation in the proximal, mid and distal calf. So you have to sample the great saphenous vein 7 times. 7 areas of ultrasound interrogation. 7 times patient will do Valsalva. If no reflux picked up, 7 times there will be distal augmentation. Is that understood? That is why it is a tedious exam. She has to keep labeling with this Valsalva or distal augmentation, the technologist. The great saphenous vein will have a spectral tracing taken at the mid and distal thigh with Valsalva, and distal augmentation of Valsalva maneuver does not cause reflux. If a duplicated great saphenous vein is seen, it should be evaluated for venous reflux too. Sometimes these veins can be duplicated. When I say sometimes, fairly often, about 25% of times. Each channel has to be followed for venous reflux. In our institution, we don't do it. However, the lesser saphenous vein is then evaluated during distal augmentation and or the Valsalva maneuver to assess for valve incompetency. Then you measure the great saphenous vein in the mid-thigh and once below the knee, and then you do the same thing there. We do not perform the perforator exam, so I don't want to go there. Because we do not treat perforators here. Imaging protocol. We look at patency. This is what she's doing. This is just for DVT evaluation. These are the images that she will acquire, and these are all the set of images. So you can see that she is doing all these images. But let me just show you this before I show you the video. All right. Here we are doing distal augmentation to this patient's calf. And where is our probe? Our probe is right here. Look, interrogating the superficial vein. When you do a normal patient, irrespective of how hard you squeeze, blood flow in that superficial vein will not cross over the baseline, right? Venous flow is below the baseline, right? Venous flow is coming from the foot, going to the heart. It's always going to be recorded below the baseline. However, in patients who have an incompetence, venous incompetence, that squeeze will cause blood flow to temporarily go above the baseline. Is this going to be staring at your face? Is it going to be a huge difference? No, it's a very slow flow, low velocity system. So she has cranking up her color gain. She's cranking up her B mode gain to show you anything. So that is why the changes on the spectral waveform are subtle. You have all seen venous reflux exams with me. We do 1 or 2 a day. And then we know that, that sometimes the changes are subtle, but they can be appreciated if you're looking for minimal flow above the baseline. Interpretation is actually very easy. Performing is very difficult. You see what I'm saying? Interpretation, oh yeah, yes, there is reflux. Oh, there's no flow above the baseline. There's no reflux. All right. Now, there is a criteria for venous insufficiency that grades it into no, mild, moderate, and severe. So you can have, and how is that told? That's told based on how long it was refluxing. Whether it's refluxing for half a second, 1 second, 2 seconds, or 3 seconds. So the yes or no, does the patient have reflux, is only when you identify flow above the baseline. But how do you grade it of how long the reflux was persistent? And that grading is done with mild, moderate, and severe, or grade 1, grade 2, grade 3, depending on the second. If it's less than 1 second, it's mild. If it's 1 to 2 seconds, it's moderate. And if it's more than 2 seconds, it's severe. So very easy to remember is your cutoff mark is 2 seconds. Okay? Less than 1, mild, 1 to 2, moderate, and above 2 seconds is severe. So very easy to remember. Sometimes, even before you put on the color flow, you can tell whether or not this particular patient will have venous reflux or no. Number 1 is first by looking at the patient's lower extremity. Are there tortuous varicose veins? Number 1. Number 2, when you do the grayscale evaluation, if the great saphenous vein is dilated, you are more than likely going to find reflux. Okay, if the great saphenous vein is dilated, invariably actually there is reflux. Okay, I'm just going to show you these examples and then we're going to go there. All right, so who's next? Louise, it's you. Okay, Louise, there is reflux here, correct? There is reflux here, right? Because this is a normal venous flow, and here we are demonstrating that there was reflux because the flow came above the baseline. This is exactly what it looks like. This is a superficial vein. Normally, in normal superficial veins, there should be no flow above the baseline. This is the baseline. Flow should only be below the baseline. The second thing tells us that this is a duration of the reflux. So if this is the second marker, 1 second, 2 second, 3 second. So this reflux was there for 3 seconds. What is there reflux? Is there venous reflux? What is the grade of reflux? Yes, there is reflux. You are correct. What is the grade of reflux? This was 3 seconds. Mild, moderate, or severe?
I think that one is mild.
You were not paying attention, I think. That is my conclusion.
You
No, what happened?
had one slide just slides before here when you measure the.
Let's look again. So less than 1 second is mild.
Severe more than 2 seconds.
1 to 2 is moderate. Greater than 2 is? No. Greater than 2 is 3. Yeah, great. Yeah. So what is the grade of reflux here?
Severe.
Severe. Very good. Now Louise is wide awake. So very good to know. This is 1, 2, 3. So you just measure the seconds and you can know and grade the reflux. Okay. Let's come to the second one. Who is that? Abhishek. Abhishek, in this particular patient, is there reflux? Why? Because there is flow above the baseline, right? Okay. This is the 5 centimeters per second mark, the 10 centimeters per second mark. This is very slow, very low reflux. Velocities are 3, 4 centimeters per second. That's what you're trying to pick up. If this is 1 second, this is 2 seconds, and this is 2.5 seconds, what is the grade of reflux? Still severe. Very good. So both of you have identified that. All right. This is yet another image. Who is this time? Who should I ask? It's back to you, Bhavna. Is there reflux? Hunter, yeah. Hunter had gone for this thing. Okay. Hunter, is there reflux?
Yes.
Okay. In this, this is 1 second. This is 2 seconds. So according to you, is this mild, moderate, or severe? Looks like it may be less than 1 second, right? Right? So this is mild reflux, correct? All right, great. Who's this? Is Sylvia. Sylvia, you talked about the trash and other household chores. You're all done with that? Okay, good. Oh, okay, great. Sylvia, if I tell you that we are looking here at the, if this is the saphenofemoral junction down here and we're looking at the superficial vein right here, is the color flow normal or abnormal? It's inverted. Very good. The color flow in a normal superficial venous system has to be blue because blood is flowing from the ankle to the heart. So right away, I know that this patient has reflux. When she identifies that, don't waste time doing Valsalva and this, that, and the other. The color flow is reversed. That's fine. This patient has reflux, but she will still sample and give you one spectrum to confirm it because with this, we cannot tell you the grading of reflux, right? We cannot tell you how many seconds it was refluxing, so she will give you a spectrum telling you how much it was refluxing. Laura, what is the grade of reflux here? Severe. Severe, very good. If this is about several seconds it was refluxing, right? Yes, Hunter?
Yes, ma'am. So when you see like a very backwards looking color pattern, like our first example there, it's all red and it should all be blue. How do you know that it may not be something with the tech that they've done the calibration
Yes.
wrong and they're kind of backwards or something?
Look at this image here.
Right.
Red on top, blue on the bottom. Apples grow on top, water is in the ocean. This is the normal color bar orientation. Okay? If this is correct, this is correct. Apples grow on treetops, so red is on top. Water is in the ocean, so blue is on the bottom. If you remember this, you will know that this color bar is correct. So the texts have not manipulated anything. Any questions here? When she puts on the spectrum here, she can see multiple varicose venous channels. Right here, even the clinician knows that there is reflux, but they want to document the grade of reflux before they treat. Okay? All right, this is again, is this normal or abnormal? If I tell you this is the common femoral vein, the saphenofemoral junction, and the great saphenous vein. Brad, is this picture B normal or abnormal? Why? It's zoomed in. Anything other than, it's a zoomed in image, so it appears dilated. Anything, is this abnormal? Let's revise, this is the common femoral vein, which is this. This is one of the tributaries of the common femoral vein, the pudendal vein. This is the saphenofemoral junction, which is right here. And this is the great saphenous vein right here. Or they've shown us the accessory great saphenous vein here. Don't worry, but this is a superficial vein draining at the saphenofemoral junction. Is this color scheme normal? Is this normal? Are apples growing on top and ocean on the bottom? Is that correct? The color scheme is right. So the tech is, her mechanics or knobology is all right. Why is this wrong? Is it wrong? And if you said yes, why? worry about this vein. It was just artifactual. Let's assume this is the great saphenous vein in this patient. If this is the great saphenous vein, is this normal?
It should be, the tributary should be flowing into that vein. I don't know if that's lined up the appropriate way.
What should be the normal color in the deep femoral vein? Just color, red or blue? Blue. What should be the normal color in the superficial vein? Red or blue?
Well, the entering vein should be red in that case, but blue otherwise.
Yeah, let's talk about the great saphenous vein. Only great saphenous vein has superficial vein. Blood is flowing from the medial malleolus all the way along the medial calf, medial knee, all the way to the medial thigh, entering the common femoral vein. So blood is flowing in the same direction as the deep femoral system, deep venous system, correct? It should also be blue. So this is normal. This is abnormal. This is the same patient. This is without Valsalva. This is with Valsalva. So while they are doing the ultrasound exam on the patient, they have to keep an eye and immediately freeze when they see red. Does that make sense? Any of you who have done these venous exams will understand it's sometimes reflux is only momentary. Right? When you do the Valsalva, there's reflux, patient relaxes, reflux goes away. So you have to capture the moment. She has to hit the freeze button when she's acquiring it. All right. Easy peasy. Is there reflux, Hunter? Okay. How many seconds if this is a second marker? 1, 2, 2.5. Severe. Correct. All right. So this is just in a nutshell what we need to do. Now I would like to show you a video. Hopefully that will pull up. It's just 4 minutes, 5 minutes.
Good afternoon. I'm Philip Bendick from William Beaumont Hospital, Technical Director and Director of Surgical Research in the Peripheral Vascular Laboratory there, and we'll be talking to you this afternoon about chronic venous insufficiency.
So we'll stop it soon at 4 minutes.
Good afternoon. This afternoon we're going to be talking about the lower extremity venous duplex ultrasound examination for chronic venous insufficiency. People are well aware of the problems of acute venous disease, the deep venous thrombosis problem, and the risk of pulmonary embolism, and that is actually the clinical problem that gets a lot of the glitz, glamour, and colorful attention. But it is not really the big picture of venous disease, and one should always keep in mind the large picture of venous disease brought about by chronic changes.
4-minute ultrasound, this is not the one. This is the one.
Let's go over some important points about this study, points that are key to giving an accurate interpretation. Point number 1, we need to determine whether or not there is a blood clot. Here's the first image of the common femoral with the vein open and closed, the junction, the femoral vein, popliteal, small saphenous, and great saphenous all appear to be fully compressible. Now that we are assured that the study is completely negative for deep venous thrombosis, or superficial venous thrombosis for that matter, our next point is to determine whether or not there is reflux. As you can see here, the right common femoral, augmentation, and Valsalva appear to be completely normal, as does the augmentation for the saphenofemoral junction, profunda, femoral vein, popliteal, and calf veins. You can see the sonographer actually just does a color Doppler image of the calf veins to prove there's the augmentation and there's no reflux determined or flow determined after release of the calf. Competency is also proven at the anterior lateral branch of the great saphenous and the great saphenous through the thought. However,
Look at this over here. Is this reflux? This is above the baseline. Is this reflux? No, this is mirror image artifact emanating from the spectrum below. If there is, this could sometimes be a complete mirror image artifact, and that is showing up only because it's a slow flow system and she is cranking up the gains. Okay, so don't fall for that.
And the great sadness to the top.
And you know that specifically because it's matched, right?
Yes, because it's got a match below. It's mirror image.
However, having looked through the entire study, you should notice that the sonographer performed provocative maneuvers, both lying down and standing. Therefore, the images here in the proximal calf, mid, and distal calf, which all appear to be completely normal, are negated by showing the Doppler signal, at least in the calf, with the patient standing, as you can see here. So once the sonographer...
So in this particular patient, first they imaged the patient laying down. There was no reflux. But as soon as they made the patient stand up, they started to notice reflux. So standing up is also a challenge. Like Valsalva in augmentation, standing up also challenges the valve. So we only do our exams standing up.
Stands the patient, it invokes a reflux signal. As you see here at mid-calf and distal calf, there's a great deal of reflux occurring in the great saphenous. So knowing that the person likely had varicose veins, mainly in the calf, the sonographer chose to stand the person, and now with provocative maneuvers employed while standing, reflux is identified. You will also want to mention the reflux identified in the small saphenous vein as seen here, as well as mentioning that the reflux appears to only be present at the proximal through mid-calf. However, the distal small saphenous appears competent. Our third point is to mention any perforators that are identified. As you can see here, there's an augmentation with flow going in the correct direction away from the probe. However, upon release, you see the color red moving back toward the superficial tissue, which would be considered reflux. The sonographer mentions a diameter measurement.
For the perforators, there are named perforators. So when you do a thorough examination, you know that there are 3 perforators in the proximal thigh, 2 behind the knee, and 3 perforators in the calf. So you just go looking for them. And how you look for them is you just travel along the deep veins with their color box open all the way up till the skin. And then you identify any vertical channels or perpendicular channels that you may see. Okay? Flow through them should also be blue. They should not be red.
And then moves on to a tributary that is also identified lateral to the shin, and we can see a color augmentation and
it changes. It's momentary.
Picture showing again reflux. The last point you will want to mention in your impression is that this was a unilateral study and it is proper procedure to just show a compression and flow in the contralateral common femoral. Actually, by the standards of the IAC, we really need to show just the flow, but we tend to also show a compression picture just to make sure and be clear that there was no thrombus identified in the contralateral common femoral and that flow appears normal.
All right, I think that is the end of my study. Any questions? Yes. You do every single?
Like you do the 7, they look at all 7 segments. You mention if there's insufficiency, and then you individually grade each one?
No, you give the severest number. So one thing to remember is like, let's say if this is a great saphenous vein, right? So if this is proximal, mid, and distal, if there is reflux in the mid Obviously, there is reflux in the proximal, because where the hell has the blood come from? It's come from the incompetent valve, correct? But, so if there is reflux in the distal, obviously there's reflux in the mid and proximal, right? So you have to tell the distal-most point along the great saphenous vein that you identified the reflux. So I can say, oh, you know, I saw it till the distal thigh, and then what was the most severe grade? Okay, any question? Yes, ma'am.
Do you do, when you do the exam, do you do both color or spectrum, or one is more sensitive than the other one?
We do, the color is definitely more sensitive than the spectrum, but to make the, like again, grading, how can you do that with color? Because the seconds only come on the spectrum. So as soon as she shows me the color change, I know there is reflux. But I need for her to show me the spectrum so I can give the time. Any more questions? Yes.
Do you always check the DVT and contralateral in our institute?
No, but our exams are always bilateral. We never do unilateral venous insufficiency. It is a bilateral exam, so that is circumvented. Yeah. All right. Thank you.